workshop that is being organized by Obstetrics and Gynecological Foundation, NAVSARI, on crisis management in obstetrics and maternal risk
धन्यवाद.
critical care support, have been all the, I would say, dignitaries and those who are just, we can say, representative of God in our society, because doctors are not other than, after God, if it comes, the responsibility of doctors only to manage and to give the life to the new young one who is coming into this world. So this kind of workshop is not only inculcating the best practices that are being practiced everywhere, but also there may be many doubts when they are coming in every doctor's mind, and when we have such a renowned faculty and guest here with us, Dr. Sunl Pandya ji. When these kind of workshops are being organized, I just as being part of district administration, I just want to say what is our part and why it should be done. When we look at administration point of view, we see there have been a drastic talk over how to reduce maternal MMR, how to reduce IMR. We have been working on it since last 75 years, since when we have got independence. Independence the day when there was around 4,000 was the maternal mortality rate, and today around 53 we are struggling how to reduce it and how we bring it at below 20. In our very small district NAVSARI, where around 15 to 16,000 deliveries are done in a year, last year 14 was the maternal death. If we compare it with respect to states or nations average, it comes higher. Second thing is maternal mortality. In this, not only a life is going, in this whole family is being collapsed. If a mother is dying, her whole family is being suffered. She may have earlier children, she may have so many implications of her death, and such kind of workshops provide us a platform that how we can work towards achieving that, reducing our maternal mortality below 20. So although I am not a technical person in terms of medical and gynecological terms, but as looking at this cream of this society and cream of this group who are working towards achieving this goal, I congratulate to the whole team for organizing such of workshops and seminar, and this kind of workshops which brings both government as well as private doctors together. This should be scheduled regularly to enhance our knowledge, to learn from each other, to progress ahead, to move ahead and to excel together. So from my part, I would say such kind of workshop should inculcate those practices and those simulation based doubt clearing sessions, so that in coming future we can reach to the goal of reducing that IMR and MMR. And again I congratulate to the whole team for such kind of sessions, and I hope we shall be organizing these on regular intervals so that best knowledge can be passed forward. Thank you so much.
Thank you, Dr. Pushpalata ma'am. Thank you for your real nice words.
We had made a little change in the schedule. Now that our Chief District Medical Officer and Civil Surgeon Dr. Aarti Kapuria has arrived, we will proceed for the small inauguration protocol. I request all the dignitaries to please join the inauguration by lighting a lamp. district.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मा पातु सरस्वती भगवती निशेषजाड्यापहा शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धि विनाशाय दीपकज्योति नमोऽस्तुते दीपकज्योति नमोऽस्तुते दीपकज्योति नमोऽस्तुते.
Thank you, Dr. Kalashri. May God bless us, all of us, for better outcome of this event and even for better outcome for mother and baby.
Thank you all dignitaries. Please, now it is time to felicitate our dignitaries, and for that I request Dr. N.D. Gajjer sir to felicitate Dr. Madam Pushpalata ji with a bouquet. Now, I request our President, NAVSARI City Branch, Dr. B.C. Chawda, to felicitate our today's Chief Faculty, Dr. Sunl Pandya sir. Now I request Dr. Styen Kasabwala, President of NAVSARI OG Foundation, to please felicitate Chief District Medical Officer Dr. Kapadia. Is Dr. Rajesh Patel sir, RCHO here? Please come on the stage, sir. I request our Secretary Dr. Vaghela to felicitate Dr. Rajesh Patel sir. Is Dr. Mayank Chaudhary, Additional DHO here? Please come on the stage, sir. I request Dr. Shefali Ben Nayak to felicitate Dr. Mayank Bhai Chaudhary. Is Dr. Dhaval Mehta, District Malaria Officer here? Is Dr. Dhaval Mehta here? He doesn't seem to be here. Dr. Pinakin Patel, District Tuberculosis Officer, is he here? No. Dr. Bhavesh Patel. Dr. Bhavesh Patel, sir, Epidemiology Medical Officer of the district. Please come on the stage, sir. Is he here? No, he's not here. Now, I have to beg your pardon. Actually, in changing the schedule, we forgot an important thing. And that is our today's chief guest, Madam Pushpalataji's introduction. I request Dr. Gajjer sir to please do it, though late, better late than never.
It's a pleasure for me to introduce our chief guest, Madam Pushpalataji. Though I have got a contact with her for a short time, but what I have realized that she is very keen and interested in maternal health and child health. This is her basic interest that I have noted. She is IAS 2018 batch, and she has worked as an assistant collector and even worked with the Office of the Commissioner of the Health for the Women. So primarily, she is working in this sector. And just now I was talking before 2 minutes. What she is concerned is how to reduce maternal mortality of NAVSARI district. Even in a short time, she knows our boundaries, she knows our limitations, and she knows the scope of work that can be done in this small district. So, Madam, we are with you, and your concern regarding working of private practitioners with the government is also our concern. And from this stage, I would like to express our commitment to you to reach or to get your goal. Thank you, Madam.
Thank you, Dr. Gajjer. I thank all dignitaries on the stage, and I request all of them to come off the dais, have your seat in audience so we can start our simulating workshop on high-risk obstetric anesthesia. I request Dr. Bharat Bhai to introduce Dr. Sunl Pandya sir, who is the main hero of today's workshop.
Before I introduce Dr. Sunil Pandya sir, I'll make an important announcement that lot of questions are bound to arise in your minds. And to answer them, we have kept a special question and answer session. That is the audience participation in the end. You are requested to be ready with your questions in the end, and if possible, please put it on the WhatsApp group OBS workshop. That is a group you are all included as members. Now, coming to Dr. Sunil Pandya sir's introduction, he doesn't need actually any introduction. As I told you, he is a renowned national and international faculty. He was born on 15th November 1964 at Kollam in Kerala. Passed his MBBS in December 1988 and MD in 1993 from Osmania Medical College, Hyderabad. He has postdoctoral fellowship in cardiac as well as neuroanesthesia from Chitra Institute of Medical Sciences and Technology, Thiruvananthapuram. He also has a postdoctoral fellowship in obstetric anesthesia from AOA, that is Association of Obstetric Anesthesiologists of India, which is our national association. He is a director of Uchwas, the first time concept of a transitional care between home and hospital. And he is a founder and current director of Prerna Anaesthesia and Critical Care Services, Hyderabad. In fact, for the first time in the country, it proved to be a trailblazer on team practice in India. He is a consultant Department of Obstetric Anesthesia, Pain and Obstetric Critical Care at Fernandez Hospital, Hyderabad. Director, Department of Anesthesia, Pain, Surgical and Obstetric Intensive Care at Century Super Specialty Hospital, Hyderabad. Presently, he is a Chief, Department of Anesthesia, Perioperative Medicine and Critical Care, AIG Hospitals, Hyderabad. Be little patient. The long list of achievements with our Dr. Sunl Pandya, sir. In addition, he is a visiting consultant at Fernandez Hospital, Hyderabad, Chief Advisor, Quality and Standards, Century Super Specialty Hospital, Hyderabad, visiting consultant at Asian Institute of Nephrology and Urology and City Neuro Center, Hyderabad. So as I told you, there's a long list of such achievement awards. I had to literally do précis writing to tell you certain important achievements. If I very broadly tell you some of the awards we can understand, he got the Best General Proficiency Prize in Class 10, National Merit Scholarship in Class 12. He was a university topper in MD Anesthesia. He was awarded the first ISA Mumbai Oration, Special Corps Award in ISACON, that is our national conferences. He was awarded 3 times in 2010, 2018 and 2019. Best Paper Award, and that is the subject at his heart. Introduction of Dashboard Audit in Obstetric Anesthesia. First time in literature and no other place than Puerto Rico in 2013. That's an international assignment. He was awarded several orations in many conferences as national state. And if I recollect, he was awarded an oration at our latest state anesthesia conference at Rajkot last year only, that is 22. He is a member of several anesthesia and even non-anesthesia organizations like ISA, ELSO, ISOM, NASOM, ISSCM, that's a critical care training that we take, OAA, SOAP, ESRA, and held important position in them. He had been organizing secretary of national and international conferences, and notable among them, First World Congress of Obstetric Anesthesia. He is a past editor of ISA newsletter. He has some patents in process at present, that is the dashboard I am talking about, and his technique of continuous saline flush technique while doing epidural anesthesia for minimizing blood tap. Also, he has a patent in process is economy intubation ramp. Now, ramp is a ramp position which we use to intubate a painfully obese patient, and that is a particular position to succeed at the intubation. He is a PG teacher, examiner, visiting professor, guide, instructor of various life support courses like, well, you all know ACLS, BLS, ATLS, CCLS, and notably OCCC. So that's a critical care obstetric training. He has been editorial board member of faculty. He holds a certificate from IIM Ahmedabad on hospital administration and management from IIM Ahmedabad. He has contributed a chapter on labor anesthesia, analgesia in a textbook of pain. He is an editor and author of Failed Spinal, What Next? So that is, he is the author there. He has, a point important to you all, contributed a chapter in Foxy document on obstetric critical care unit minimum standard designing. So he is very fond of doing that. He is a peer reviewer in various journals, 23 publications to his credit, and national and international journals. Have conducted over 52 workshops in labor analgesia and 26 in obstetric critical care. I think this could be the 27, sir. And nationally and internationally. He has introduced the today's subject, simulation-based training in obstetric anesthesia and critical care for the first time. For the first time. Sir is deeply involved in research work also. he had done research in low-dose labor analgesia, USG guided TAP block. Now that is a block, I think some of us, at least many of us have started giving post-cesarean surgery. That is a transverse abdominal spleen block. A very good block for the post-operative pain relief to the patient. Non-invasive ventilation in pregnancy. And ERASE is early recovery after surgery. That is our topic of choice nowadays in elective cesarean sections. So he is passionate about certain things. The dashboard thing and mesh board. Well, I also have to understand what is mesh board. I have still come to a little understanding of dashboard, sir. Surgical obstetric care. He is very fond of teaching and training PGs. And as I told you, designing and planning of ICCUs and OT suits. And of course, he likes listening to music and even playing them. And he loves nature photography. So today we have such a learned and multifaceted personality with us. I hope you make most of it. And now I invite sir to please start your workshop. Thank you, sir, for coming here and enlightening us.
Thank you, sir, for the elaborate introduction and absolutely embarrassing. But I'm really humbled and at the same time honored and privileged to be here amongst you. And thanks to our DDO Pushparataji for gracing this occasion and all the dignitaries who were on the dais. I profoundly thank the Society of Obstetrics and Gynecology NAVSARI as well as ISA NAVSARI branch for the conduct of this workshop, because whenever you do obstetric simulation or when you talk about obstetrics, it is symbiotic relationship. Anesthetists cannot work without an obstetrician and vice versa. And mutual respect, mutual admiration and mutual communication is what is vital to take care of a patient on a routine basis or even during crisis. Our focus of workshop today will be on the crisis management in obstetrics. Of course, generally when I do these workshops, it's for the entire day, 8 a.m. to 6 p.m. So we have truncated that to about 3.5 hours. But I'll try to do whatever best we can do in this 3.5 hours for at least run through our 3 scenarios on this simulation. So basically, why, it's an honor for me to be here. Why simulation in obstetrics? When you talk about simulation, basically simulation is a very valuable teaching tool. It helps us to assess our procedural skills and efficiency and proficiency, and repeated simulation exercise before a major case reduces errors. Like suppose if I'm doing a placenta accreta or placenta percreta in my practice or adherent placenta in my case. So if you have a close communication, if you have a hurdle with your anesthetist, with your neonatologist, with your surgeon, with the vascular surgeon, and before you start the case, the outcome is much, much better. And simulation is nothing but that exercise. So it provides us to acquire knowledge, upgrade our skill, and importantly, what we expect is by repeated exercises, our skill retention is far, far superior than actually what we listen to a routine PowerPoint presentation during the conferences. And importantly, yes, bottom line, enhancing patient safety and skills. But more importantly, simulation also helps us in medical decision making and leadership development. Because whenever there's a crisis, everybody will instruct everything and everybody will do nothing. Outcome will be unsatisfactory. So leadership qualities and leadership development is very, very important during crisis, because that is what we expect. And importantly, as I said, it helps us in upgrading the skill. But more importantly, the soft skills. We know that soft skills are very important during crisis. Like if the air pilot has to take off or land, he has to be fully attended, and communication has to be very good between the cockpit, between the tower, between the traffic and everything. So communication skill, when I say communication skills, 75 to 80% of medical errors today happen because of poor communication, interpersonal communication. And what we expect is closed loop communication skills. Time management, especially when there is a crisis, we know especially when you have acute collapse, you have got only few minutes and you need to do all possible things, the best possible things provided in those 2-3 minutes. Like recently, if you see, there was a demise, maternal death. I was just talking about the breakfast with Dr. Tarun in Valsad a couple of days back, a ruptured uterus, and by the time the mother was shifted to head called Surat, they lost the patient on the translator, probably they received the patient dead. So time management is very important. Most important is the team building. So whenever there is a crisis, it is, I am not God. Madam Pushpalata ji was very kind enough to say that we are next to gods, but we are just human beings. More importantly, team building is very essential, because unless we have a team during crisis who can perform their respective roles, we cannot give the best. So how you build up your team is what we are going to learn today. And more importantly, once you build up the team, no egos, no barriers. We are not working in silos. We have to work without any barriers. And of course, one is a commander. You cannot have 10 commanders in this, 10 captains in the pilot. There is only one captain, and remaining all will be the people who support that. So cooperation between the team members, adaptability to the crisis is very important. And algorithmic approach, problem solving. Okay, this is my plan. This has failed. I go to plan B. Plan B has failed. I go to plan C. So all these things have to be crystallized in order to give the best outcome. And resolving conflicts. Yes, whenever there is a crisis, the difference of opinion is going to arise. Like, so for example, the obstetrician tells the anesthetist, give prostaglandin, patient is having atonic PPH. Anesthetist says patient is asthmatic, I can't give prostaglandin. So at that moment of time, ego should not come. What is best for the patient? If not this, what is the next best thing which I have in my armamentarium? So those things, rather than, because patient is asthmatic. And the problem, then the friction will start there. So we don't want any conflict. So conflict resolution also will be discussed briefly in this thing. And importantly, it's like simulation, like nothing like storytelling. What we expect today during this workshop brief workshop of 3.5 to 4 hours is, we expect participants who are, each one of you will be calling you by rotation, 6 or 7 of you, and we expect you to make mistakes because we are humans and to err is human. But we have to learn from our mistakes. Learning from our own mistakes is a slow process, but learning from others' mistakes, learning from mistakes done on simulation is a rapid process, and that's how we learn. And we as facilitators, we have Dr. Sheetal and Dr. Bharat and everybody here who will be assessing the performance and will debriefing. So the errors that are identified during the performance of scenario, we'll be debriefing them, and then that's how we'll learn further. So what it has been conventionally seen is, whenever you perform a mistake, you debrief, the skill retention is far, far superior, and translational into the practice also improves. So definitely it is very important in our practice. So briefly about today's workshop. As I said, whenever the mother collapses, acute collapse, A, B, C, D, E, U, P, S. These are only things you have to remember. You just remember these are the causes which are going to cause collapse in a parturient. A, B, C, D, E, U, P, S. Anaphylaxis, anesthetic causes, which are fortunately very, very rare. In fact, if you ask me today's, the recent trends in anesthesia causing maternal death is one of the lowest, last cause, fortunately. So, second is bleeding. The most common cause of maternal death today is bleeding. C is for cardiac. The pentad, I'll be coming to it. Drugs, the medication errors, which can happen because of wrong labeling, or we have read few case reports where inadvertent intrathecal tranexamic acid has been given intrathecally, and we know the consequences. E is for eclampsia, hypertensive spectrum, the second commonest cause of maternal death, and the 4 T's, uterine causes, the tissue, tone, thrombus, and trauma. Again, as I said the day before yesterday in Valsad, the trauma, the rupture of uterus was the cause of maternal death, which should not happen in today's care. And P is for pulmonary embolism, an embolic disorder like amniotic fluid embolism. S is for sepsis. So whenever the mother collapses, just activate your process. Is it A, B, C, D, E? One of the cause will fit amongst any of these things, and you can activate appropriate pathway. So whenever we talk about obstetric shock, the commonest cause of obstetric shock is hemorrhagic shock, followed by septic shock, and the cardiogenic shock. Obstructive shock, like embolic shock or pulmonary embolism, and anaphylaxis shock, fortunately is rare, but yes, we have to keep in mind. And this is one shock which is an amalgam of hypovolemic, hemorrhagic, and urogenic shock, the uterine inversion, which can lead to, and we know the management criteria. So whenever there is a collapse, we have to know the underlying maternal physiology and the fetal physiology, because both are vulnerable during pregnancy. And importantly, both the mother and the fetus have differing physiological profiles. And as a perioperative physician, intensivist or anesthetist, I need to know the changes that happens during pregnancy and impact during pregnancy, impact during crisis, and simultaneous assessment and management. It's not that I assess the patient first, I send the labs, and then I manage. So we need to do A, B, C, D, E, and A, B, C, and CAB simultaneously, because importantly, constituting a multidisciplinary team at point zero, hour zero is what is important. Yes, I need help. So if I need help, whom to call, and all these things have to be there, because at the end of the day, as a perioperative physician, intensivist, I want to give best to both the lives. I want to save the mother first. At the same time, if possible, I want to save the baby as well, so that we can reduce, as Madam Pushpataji said, both MMR and IMR in our country. We know that today is the commonest, the lethal triad for fetal demise is hypotension, hypoxia, and anemia. So anything that causes maternal hypotension, anything that causes maternal hypoxemia, anything that causes antepartum hemorrhage is a threat to the fetus, and we need to keep this in mind. And we know the physiological, I don't want to go into the details, but the cardiovascular changes, the pulmonary changes, the renal changes, and the hemostatic changes. In a nutshell, a pregnant patient, they breathe more, they pump more, they clot more. It's a clotting machine. And we need to understand these changes so that we can manage appropriately and we can minimize the end organ damage. But importantly, the risk of aspiration also is there. So when we talk about A, any of these causes can cause anaphylaxis, right from the point of induction of anesthesia to extubation. So most commonest culprit is antibiotics, which are commonest causes. And not to forget, uterotonics and also can be the cause of anaphylaxis. And when you have anaphylaxis as a cause of shock, the drug of choice is no second thoughts, adrenaline. So if you don't have intravenous access, don't waste time in IV access, just give intramuscularly half cc or 1 cc. And once you get, if you have an IV access, just take 1 ml of adrenaline, make it 10 ml, give 2 cc intravenously. And subsequently you can give hydrocortisone and Avil and other things. But importantly, do not delay in giving adrenaline, the drug of choice. The value of blood gas. How many EBG machines are there in NAVSARI? About 3? Yeah. So everybody, whenever the mother becomes sick or you feel that something is not correct with this mother, do an ABG. ABG will not give you a diagnosis, but it will tell you the severity of the magnitude of problem. So if the ABG is deranged, like this patient with a patient case of eclampsia, severe preeclampsia with pulmonary edema, but normal preeclampsia profile. The platelets were normal, creatinine was little high, but importantly SGOT, SGPT were little borderline high. So if you look at the blood parameters, obstetrician definitely will wait for giving by giving betnosol, wait for 36 hours for the fetal lung maturity and then deliver. But EBG, doing an EBG, it will tell us do not wait for 36 hours, terminate immediately. Because if you wait for 36 hours, your kidney injury is going to prolong and your kidney injury is going to worsen. So EBG can also help us to decide the modality of termination. The decision to terminate the pregnancy also can be interpreted from EBG. Like this example, if you see, pH was 7.0, extreme acidosis, minus 21 base deficit. And this was done at 22:05, 4th December. And we terminated the pregnancy, and within next hour, like 6:21 a.m., 5th December, just within 10 hours, you see pH has come back to normal and base deficit is corrected. But if you wait on this for another 6 hours, patient will end up with acute kidney injury and will be on dialysis. So ABG have a low threshold to do blood gas analysis. It helps us to decide termination. The commonest cause of mortality today in our country, major obstetric hemorrhage. Do not allow hemoglobin to fall to these levels. We don't want hemoglobin. This was the patient who bled 12 liters, 2 times of blood volume in less than 8 minutes. So in 8 minutes, patient is losing twice the blood volume. So you can imagine the stress level of anesthesiologist at the head end pumping to maintain the blood ABCs of the patient. But we need to be prepared to tackle the situation. So how many blood banks again are there in NAVSARI? I want to know. 2 blood banks. So what I wish is empower this blood bank, have all blood and blood components. I was just told over the breakfast by Dr. Tarun that they don't have cryoprecipitate here. Pushpalata ji is here. I encourage that at least availability of cryoprecipitate in the blood bank as a component is very, very vital, because when the mother lands up with coagulopathy, cryos are the first that we administer. Yes, we have a replacement for cryo also, like fibrinogen concentrates are available currently, but 1 gram of fibrinogen concentrate costs about 15,000 rupees, and you need to give minimum 3 grams, so 45,000 rupees just for fibrinogen, very expensive. So cryos are the building blocks, especially in obstetric coagulopathy, and we need to have that in place. And when you cannot control the obstetric hemorrhage, have a low threshold to use vascular clamps. How many of you use vascular clamps here when the blood bleeding is out of control? We don't use, because we are not exposed to that. So yes, it requires a little learning curve, and learning curve is very essential. You just have to palpate the aorta, which is lift the uterus, palpate the aorta, and just below the kidney you have to apply the clamp. It will at least save the mother until the vascular surgeon comes.
What we do is, in periphery, that I have practiced also, that external aortic compression.
I am coming to that. So yes, if you don't have this, then manual compression is the alternative. So external aortic compression, but importantly, external aortic compression, fatigue sets in within 5 to 6 minutes. And the surgeon has to be really quick to control the hemorrhage, because sometimes when the patient bleeds, we just have to see to believe it arise. And whenever the patient bleeds, the lethal quad and the lethal pentad has to be prevented. The hypothermia, acidosis, coagulopathy, hypocalcemia, and hyperkalemia. Because when you are giving stored blood, which is there in blood bank beyond 10 days, 15 days, 20 days old, if the shelf life of blood is 35 days, but any blood which is more than 20 days, we know the potassium load is about 8 to 10 millimoles in that stored blood. And if you are giving massive transfusion, more than 7-8 units at a time, you end up with hyperkalemia also. So you have to be very, very careful. So you need to have this. We developed the strategies of 10 commandments in our hospital. It works very well. So whenever the patient bleeds, just follow these 10 steps and you can control the bleeding. I can give this PPT to Tarun and you can have it. I've got all the presentations. In fact, I'll give it to Tarun so that you can use it in your practice. But it definitely, when the patient bleeds, this 10 commandment approach helps in surviving that. As a clinician, not everything that looks same is the same thing. So we need to have a little differential diagnosis in mind. We should not have a tubular vision, have a wider vision. Like any pregnant patient with hypertension with epigastric pain, we think it's an imminent sign of eclampsia. It is epigastric pain and stretch on the Gleason's capsule causing or imminent sign of eclampsia. But we have had several cases where we had acute pancreatitis, series of cases, presenting as acute pain abdomen, preeclampsia with severe features, HELP syndrome, HELP with pancreatitis. And when pancreas are involved, like this is typical saponification of fat that you see, which you need to make out. And when we did a CT scan, there is a necrotizing pancreatitis. You can see air bubbles. So any patient who does not improve, has persistent epigastric pain, think beyond eclampsia or think beyond imminent eclampsia. It could be acute pancreatitis. This was the case of acute subcapsular massive hematoma of the liver. Like patient has severe epigastric pain. She delivered 12 hours back. Next day morning, she was made to walk and she collapsed and fell on the floor. And when we just put an ultrasound on the abdomen, we found there was some swelling in the liver. Then we got a CT scan done and we found there is massive hematoma of the liver. So presented with epigastric pain. Suppose this patient, we could have just resuscitated and would have settled, but had we not investigated, we would have misdiagnosed and could have ended with massive liver bleed. So always keep your differentials alive. This was another patient who came in the midnight with severe pain abdomen, like labor pain and features of HELP syndrome. WBC count to 53,000. I was not happy with 53,000 because she didn't look like sepsis, But when we got a peripheral smear check, I called the pathologist to come in the night, it was a Sunday night. Pathologists, they don't have night duties. But this particular case, I called the pathologist to come and look at the smear, because this patient came from endemic area of Kurnool near in Andhra Pradesh, and we found sickle cell crisis. So she was a case of sickle cell crisis with HELLP syndrome. So what I mean to say is, pregnant patients have plethora of problems, and we look what is visible. As a clinician, we need to look what is invisible. And that is what we'll be talking about. So basically, this is a case of preeclampsia with HELLP with sickle cell crisis. And we know that if you miss the crisis, it is going to be the cause of fetal mortality. And we know perioperative what sickle cell can do. So please develop an idea of having a wider vision, because our idea is to identify the black sheep, and that is what is important. Sepsis is another cause. The third commonest cause of fetal death is sepsis. And when we know that when there is sepsis, the 5 things are very, very important. Our one bundle, 5 things in our one bundle are: measure lactate, send cultures, give empirical antibiotic, give fluids, start vasopressor inotropes, and 6th step is terminate the pregnancy. So you just have to remember this. It should be in your DNA. If I think of sepsis, go through this, and invariably you succeed, and you have a good outcome. Not to forget the subtle and the most important undiagnosed cardiac causes of maternal death. Because many a times everything is fine, mother aa gaya, delivery ho gaya, and she collapses. And nobody knows why the patient died, and suddenly you see the nursing home being ransacked by the mob of attendant, the family. But see, honestly, we have seen that there are so many occult cardiovascular diseases which are undiagnosed in pregnant women. It could be cardiomyopathy, it could be severe mitral stenosis, it could be aortic stenosis, it could be pulmonary hypertension. And unless the disease is of severity of certain magnitude, they won't have the telltale signs. Because pregnancy, if you ask me, about 15 out of 20 women will have some sort of breathlessness, some discomfort, some pedal edema, whether it is a pathological pedal edema or a physiological pedal edema. Is it a pathological breathlessness or a physiological breathlessness? As a clinician, we need to have that subtlety to differentiate what is pathological, what is physiological, and what is pathognomonic. So PND is never pathognomonic. Paroxysmal nocturnal dyspnea is never is never physiological. Similarly, S4, S3 heart sounds are never pathologic. Never physiological. So you need to remember these things, and you need to have this thing. And dissection, fortunately, is not uncommon. Not very common in our country. But how many of you have encountered Marfan syndrome? Arm span. Just if the patient's fingers are touching the knee, a patient is a Marfanoid patient, and just put a probe on the aorta. If the aortic diameter is more than 4.5 centimeters, it is a dangerous patient. She is a very dangerous patient, because this patient will be NIHA class 1. They won't have any breathlessness. Like if you ask me, tight mitral stenosis, severe pericardial cardiomyopathy, they have some sort of breathlessness at least. But Marfan syndrome, the mortality risk is very high, dissection risk is very high, but there will be NIHA class 1. So you just have to keep those things in mind. And when we know that if we have to tackle a cardiac case, PAC R square. Just remember this PAC R square. Preload, afterload, contractility, rate, and rhythm. You just have to manage 5 things, and you can salvage the patient. But more importantly, what I want each one of you to implement, and probably this can be easily done in government hospital, is introduction of modified obstetric early warning chart. This chart we developed in 2008. Basically, this is what they developed in National Health, NHS UK. We modified to our needs, and basically it has different parameters with a red and yellow trigger. And 2 yellow and 1 red, the consultant has to see the patient. If it is persistent red, action has to be taken, alerts have to be raised. So definitely it helps us, because once you incorporate modified obstetric early warning chart and you develop appropriate tools to act upon, like this patient is having tachycardia, tachypnea, and fever. So probably I need to go via sepsis pathway. This patient is having tachycardia, tachypnea, breathlessness. Is it respiratory or is it cardiovascular? And I can appropriately I can activate cardiopulmonary pathway. This patient is having tachycardia, tachypnea, but she is bleeding. So I need to activate hemorrhagic pathway. This patient is having tachycardia, tachypnea, but having breathlessness and crepitations, and BP also is high. So I need to activate the hypertension pathway. So you need to develop this obstetric warning chart and appropriate tools to be incorporated so that appropriate pathway can be activated and you can salvage a mother. And believe me, these tools are very, very essential and they are very, very helpful. So that this, once you activate the sepsis pathway, we know what to do. Once you activate a hemorrhage pathway, we know what to do. And I'll be discussing in detail about those things. But importantly, if you are bothered about the entire modified obstetrical warning chart, just concentrate on these three signs, quick SOFA score: the pulse rate, the blood pressure, and the respiratory rate, the blood pressure, and sensorium. So hypotension, altered mental status, and tachypnea. These are the three vitals which are very, very important. So at least if you have a mother who is breathing rapidly, who is altered mental status, is very grave. She needs to be stabilized and urgently transferred to a higher center. And if we miss all these things and she lands up with a cardiac arrest situation, you have to be, it requires high intensity training. And we have a guidelines, AOA has produced its guidelines last year. I was the lead author of this paper. But importantly, it's freely downloadable from the Google. Just Google search AOA guidelines on maternal cardiac arrest. But importantly, we'll discuss in detail about these things. But resuscitatory hysterotomy is what is important. If you cannot resuscitate the mother within 3 to 5 minutes, 4th minute, start resuscitative hysterotomy or perimortem delivery, and 5th minute deliver the baby, because delivering the baby is not for the survival of baby but survival of mother, because we know that once the baby is out, the uterus contracts and you can achieve ROSA early. So these things are very, very important. We'll go in detail about it. But as an anesthesiologist, perioperative medicine, not to forget the pain management of patients in the ICU. And importantly, what we need to do is, when you have a sick mother in ICU, the baby also is sick in neonatal ICU. And co-ICU admission, that is, mother is admitted in ICU, baby is admitted in ICU, and we need to develop maternal bonding. It's very, very important that maternal bonding is developed, because as an obstetrician, I don't want my mother to have lactation failure. When the mother is sick in ICU for several days, and if they don't feed their child, the mother will fail to lactate and the child will be on supplemental feed, and that is one of the cause of higher perinatal mortality rate. So do not forget the maternal bonding part as an obstetric intensivist. And if you cannot bring the baby to the mother, at least bring the electronic baby to the mother, like we develop electronic bonding via NICU Connect. So these things are very, very vital, this thing. So with this brief thing, I conclude my talk here. We'll proceed with simulation. And as I said earlier, I think you must have received the handout. What we'll do is, we need about 6 to 7 volunteers for every scenario. 6 to 7 volunteers. And to begin with, 2 people will enter the OT or the ICU. And you will see the patient, you can talk to the patient can talk to you. Whatever you want to ask, history taking, you can examine the patient. And subsequently, the patient will behave a little erratic and you need to manage. So can I have the Sheetalji, if you can just take over, I'll just give the first scenario to the patient.
Yes, we request delegates to come voluntarily for this simulation workshop. So we have created 4 scenarios. So we really need 2 people, one obstetrician and nurse will be coming for that scenario. They'll examine the patient, and being the leader will be the obstetrician, and they'll call anesthetist for help or for the further management. So we need 4 of anesthesiologist and 4 of obstetrician to be ready for this scenario. And of course, if they need any help, and they'll call more people inside. So the black box is our OT or the ICU, where the patient and the things will be there. And here we'll see there how they are dealing with. And
so can we have 6 people?
So we have 6 people. So obstetrician, I'll call upon Dr. Akash, Dr. Jignesh, Dr. Kanchan, Dr. Vaibhav, and if we really need, then Dr. Chetana. So
basically,
whoever there will be ready for this. And for anesthesiologist, I'll call upon Dr. Chintan, Dr. Sandeep, Dr. Uma, Dr. Ashalata. And yes, of course, if they need more help, they'll call another anesthesiologist and even obstetrician for this.
so this patient is a 36-year-old lady with a little high BMI. She's a term 38 weeks of gestational age, no adverse medical history. CTG reveals type 1 dissolution, but she comes in labor and is about to deliver. She is about to deliver. So we can proceed.